Thank you very much. I want to thank the members of the organizing committee for this workshop and for inviting me to provide some reflections on my experience in doing some research in this area in the context of Oregon, primarily the context of hospice programs in Oregon. Okay, how do we get this to flip? There we go. Okay. I wanted to draft a little bit off of what Dr. Pope just said and indicate that most of the issues that he just referred to in terms of the strengths or the weaknesses that are of the requirements on physician-assisted death that are being looked at in other countries, those are not new issues. They were present, many of them, in the Oregon discussion in 1993, 1994, and then in 2017, the Oregon legislature took up Senate Bill 893, which was to be an amendment to the current Death with Dignity Act, and a patient who had executed a lawful advance directive could identify an expressly identified agent, also called an attorney in fact, if the person ceased to be capable over the subsequent to receiving the prescription, but not necessarily having received the medication. The expressly identified agent doesn't say they have to be a physician, doesn't even have to say that they have to be a nurse. They can collect and administer the prescribed medication. Well, the question to think about is why was that kind of process sort of debated and sort of refused in 1993, 94, and also in 2017. So I think if the question, our discussion is focused primarily around what's in the best interest and what's patients, what's going to promote patient rights, we might get at some of these questions a little bit differently. But as the legislation was developed in Oregon in 1993-94, there were several stakeholders besides patients that were identified by the drafters of the law from Oregon Death with Dignity and Eli Stutzman, the Portland attorney that was the primary architect of the law. So certainly providing some expanded rights for terminally ill patients was part of the discussion, but also considerations for physicians and pharmacists. Safeguards are built into the law or into the act to ensure that physicians would be immune, physicians or pharmacists would be immune from prosecution. They would not have to make quality of life assessments about extraordinary suffering and so forth, but would just be responsible for determinations of capacity. And there was a protection built in, no legal duty of participation for if a professional had conscientious objections based on personal values or religious considerations and so forth. So there's protections or safeguards, if you will, to ensure the integrity of the moral agents that are assisting or participating. And third, an area that we've sort of alluded to but really haven't talked much about is there are certain protections built in to assure the public that this particular process, very new at the time, was undergoing or being carried out in what the drafters of the law called a model of reasonable regulation. They didn't want it to be so prescriptive that it micromanaged the physician's decisions all the way through. On the other hand, they were trying to avoid, and you have to think about the context, 1993-94, sort of the Dr. Jack Kevorkian context in Michigan, a kind of unregulated system. They were trying to avoid that. They were trying to provide a kind of middle way, a balanced approach here. With that in mind, there's a lot that the law doesn't address. One of the physicians who I collaborate a lot with in Oregon on several respects has prescribed medications for many of his patients, says that the problem with the law is that there's no implementation procedure. Again, it doesn't prescribe, and Katrina Hedberg, who is here somewhere, there you are, and we'll talk more about this tomorrow. I mean, again, she is very clear in an article published a few months ago. The law does not address what happens from the time the prescription is written until the patient's death. There's a level of unknowns about in at least 50% of the deaths that are recorded about various kinds of things in which we don't know if this provider is present, or the duration between ingestion and unconsciousness, or ingestion and death. What's there legally doesn't necessarily preclude others, other communities, other providers from developing best practices. And what I want to suggest to you is that one of those practices, or one of those contexts for articulating best practices, has been in the hospice setting and the hospice communities in various states. As you can see by this graph, depending on the state, 75 to 90% of the patients that utilize physician-assisted death in these particular states are enrolled in hospice. Hospice, in certain respects, becomes an important kind of safeguard for many of the considerations that you might have worries about if it was just a one-on-one relationship with the patient. So hospice provides, I think, a kind of very important safeguard setting. The law only utilizes, and you guys can correct me if I'm wrong on this, but I think hospice is only referred to once. It says the physicians have to inform patients that hospice is an alternative along with comfort care. That's all that's mentioned about hospice, and yet, again, the context is 90% in some of these states, in Oregon 90%, Colorado even a little bit more. Hospice is the circumstance or the context in which some of these procedures are in fact implemented. So in the 5 minutes I have remaining, I wanted to just mention a couple of studies that I've engaged in, trying to get at that context a little bit more. A 2010 study that looked at documents developed by hospice programs in the state of Oregon and did sort of a document analysis, and then a 2014 study of programs affiliated in the Washington Hospice and Palliative Care Organization. Those organizations have subsequently sort of merged together. The outcome of this study, some of you might have picked up outside. There's a 2-page handout about sort of kind of a template for questions for hospice programs to consider, and that was something that came out of this study. Part of what we did in this particular study was looking at the documents as well as some site visits that we engaged in to see what the positions were of various hospices. And the typology we developed is much more complicated than this slide, but for simplicity purposes, just to indicate there were 3 basic positions that hospice programs affiliated with. Some identified them, again, the blue here is Oregon and the orange is Washington. Some identify them as themselves as non-participating hospice programs that largely had to do with, in many circumstances, because of religious considerations. Some were not religious but felt this was so outside the scope of hospice care as they defined it. I have to mention that amongst all of the programs that defined themselves as non-participating, no one indicated they would discharge a patient from hospice care because they made a request, an inquiry, or had a conversation. A second sort of grouping are sort of clustered around concepts of neutrality. This particular hospice program would be neutral. Some use the language that Timothy Quill and Christine Cassell articulated about a studied neutrality. Others engage in or developed what's called a program of engaged neutrality, but a sense of neutrality and sort of basically leaving the question up to relationship between the physician and the patient. And then in both states, the numbers of sort of the percentages of hospices that deem themselves to be respectful participants. They respect patient choices. They respect the integrity of the physician-patient relationship. They'd also respect the determinations of, say, a nurse to not continue to provide care because of conscientious or religious considerations. We wanted to see, well, what kinds of values are back of these particular positions. And so this particular slide combines the two states together. You'll see that the self-determination value is sort of ranked the highest in terms of how frequently it shows up. What was interesting to us is this one, the fourth, hospice neither prolongs nor hastens death. That was kind of a pillar of hospice philosophy when Cicely Saunders sort of developed the philosophy of hospice back in the 1960s. That was the core pillar of hospice, to differentiate hospice from life extension, no matter what, and euthanasia program as she understood it in the United Kingdom. Non-abandonment was a very important consideration, and we wanted to try and get at that a little bit further. This was the most sort of where we found more differences among the various hospice programs in terms of whether they would allow a staff member of hospice to be present at the time of ingestion. So you've got differences in Oregon in terms of whether they permit some staff. Same with Washington. So two basic points about, I need to hurry here, sorry. The two basic points about patient access that have come up out of this context. Because there's no legal duty to participate on physicians in the state of Oregon and all the other jurisdictions, there's also in Oregon no legal duty to refer as well. And that's become a sort of obstacle, if you will, for some patients to have access. Notions of the costs of medication have dramatically increased. This is the preferred one. It's now at $4,000. So other kinds of combinations that are less expensive have been introduced, but those have some additional side effects. Last point, if I can just finish this off. This is, again, there's a slide out there, or a handout out there. This is what the system looks like. There's a lot of hurdles. This is what's been drafted by Kaiser Permanente initially in the state of Oregon, now being introduced to other healthcare systems. It's called the Patient Navigator system. And it's difficult to navigate for any patient, any physician. So what you have right up here in this box is you would have a coordinator, usually a social worker, but in some Kaiser Permanente facilities in Oregon, they have a pharmacist do this. But they sort of coordinate this whole process, which includes looking at finances. Over here, this is where you do the capacity determination. Here are the requests, and working with the pharmacy, ultimately to the ingestion and the submitting of the reports to the various state reporting bodies. So sorry for going over my time, but thank you.